Good afternoon, and welcome to Mastering Image Management, a complimentary webinar from HealthSystemCIO.com, sponsored by Perceptive Software. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of HealthSystemCIO.com, and I will be your moderator today. We encourage you to ask questions today. You can type them in at any time in the Q&A box in the lower right-hand corner of the screen. We'll leave the default set to all panelists, and we'll pose those later in the program. You can download the deck using the URL in front of you. There's a shortened URL at the bottom of all slides, and I will also send it out in the chat box. And we will have an archive of today's event that should be available within 2 business days. You'll receive an email when it's ready, and a separate registration is required. Just to see how we're going to spend our time today, we're going to go about 45 minutes. First, we're going to hear from Dan Kinsella, EVP and CIO at Cadence Health System. Then we're going to hear from our sponsor, represented by Troy Oliphant, Global Healthcare Solutions Manager with Perceptive Software. And then we're going to have our Q&A with Dan. So without further delay, I want to turn it over to our featured speaker, Dan Kinsella. Dan, thanks so much for joining us today.
Thanks a lot, Anthony. It's a pleasure to be with everyone. So good morning in the Midwest here. It's still morning, and on the topic of mastering imaging management, the word mastering is a little intimidating, and that's clearly aspirational. I don't claim to be a master, but we have gone down a path to begin to manage images across the enterprise. By way of personal introduction, I'm a veteran of healthcare IT, more than 34 years. 2 years as a CIO, so I'm still a recovering consultant. And by way of what's going on at Cadence, we're in the second month of a very exciting merger with Northwestern Medicine. So we're kind of living the dream here, so to speak, of how some of this planning comes to play. So when we just to level set, when we talk about the objectives here, so what is image management? When we talk about imaging, the scope of imaging is broad, and it's also changing. So clearly a variety of formats and standards from DICOM and non-DICOM. Pictures are becoming a bigger piece of the action with the explosion of personal devices and certainly the legacy imaging as we would think about it with business documents. So there's a wide array of images to be managed, and why should this be on your list? What's the purpose now for managing images? And I'll argue later in the conversation that the purpose for why it's important to manage images really has changed quite a bit from the days of PACS 1.0. As we moved from film to digital. Today, when we talk about the triple aim context, better outcomes, better patient experience, and lower cost, would argue that that's emerging as the broader purpose for why it's important to manage images. Before I go further, I want to certainly thank a couple of my teammates at Cadence who helped contribute significantly to this presentation. My IT team, Donna Moschek, Ellie Lapidus, and Rob Desautel, so I couldn't have done this without a lot of their help. So when we think about this, the challenge, why is this difficult? And some of the challenges are directly related to the technology itself. We talked about the variety, the advances of the powerful diagnostic equipment, the mega multi-slice CT PET. When you think about just the storage of what it used to take for a, quote, simple X-ray in the old days to now a gazillion slice CT scan, it's really staggering. Quality available for the diagnosis, but certainly from an IT perspective, challenges regarding bandwidth as well as storage. The next point has to do with the generational span of technologies and vendors. We're now at a situation where there's second and third generations of equipment, too often in the same workshop of some of our radiologists. ergo the term, the swivel chair workflow, where you go from one workstation to the next. Image transfer has become a challenge as patients become mobile. Their relationships with providers are becoming more diverse, and so the ability to move images from one location to another instead of tucking them under your arm and throwing them in the backseat of the car on your way over. Discussed bandwidth and storage, and then certainly the workstations, the thick client and high-end workstations that continue to advance. So those are some of the challenges directly related to technology, but it's not just the technology. Some of the challenges related to the business, this has to do with who's the customer nowadays. Whereas in the old days, I think in PACS 1.0, the customer was really the referring physician, if you will, the doc who ordered the X-ray, and the radiologist catered to that person. The history of diagnostic imaging, really as a revenue generator, concession stand, if you will, was one of the high drivers of revenue in most hospitals, resulted in proliferation of a variety of specialty image capture and archive systems. And an inadvertent consequence of that was the islands of information that resulted. In parallel to that, over the last 10 years, really, significant growth and expansion of electronic medical record adoption. So that's really kind of raised the bar in terms of expectations of clinicians as well as patients regarding access to their record. Clinical integration is one of those terms. If you ask 5 people what that meant, you'd get 5 different answers. But for the sake of this conversation, it's really a stretch of the scope of concern, if you will, for people that we want to share images with, whether they're employed or closely affiliated or even just casually affiliated. And there's a lot of provider market consolidation, mergers and integrations, resulting in sometimes double-digit number of legacy PACS systems. Talked about mobility and some of the teleradiology alternatives and subspecialties. So some of the barriers that had to do with time and place are being alleviated with some of these technologies. So this is big science, big investments, and it's all in the nexus of a healthcare landscape that's undergoing a transformation. I'm as I mentioned, a recovering consultant, a framework guy. I find this diagram useful to consider both the current and future state. If you start up at 1 o'clock in terms of preparing the patient for the X-ray, then actually capturing the image in a variety of locations, modalities, time, and place. It's not just the basement of the hospital building anymore. The professional read of the X-ray, whether that's local or remote, 24/7 with functions like Nighthawk, then retrieving and comparing the past images. That's some of the value. And what is the value, the history? We've got a legal medical record responsibility for 21 years past the age of majority or 7 years past the age of majority for a minor. But beyond that, what's the value of keeping that? You'll get into discussions of what's worth converting, what's worth retaining. Reporting the impression then after the professional read, that gets back to the ordering physician. So this is what I saw, this is what I think, and some collaboration on that, which gets into the consult and the EMR space. And then finally, archiving. And we'll talk more about things like vendor-neutral archiving, which I think are part of the future technology enablers that will be important. So as we evaluate solutions at Cadence for consideration, we look at the benefits that they derive as well as our position to deliver them. So if you look at things regarding the position to deliver, I'm an early adopter of the concept of, and a believer in the notion that deconstructed PACS is something to understand because of its ability to help you improve your position to deliver on these capabilities. The components include the things listed here: image capture and workflow, image exchange, a diagnostic viewer, and things like the vendor-neutral archive. The drivers of the benefits include things from the business, so merger integration and platform rationalization. We can consolidate for disaster recovery and lifecycle management, so we're not dealing with 10 different PACS systems over time. We can minimize our data migration associated with the technology evolution. If we've already migrated the images to a vendor-neutral archive, then the trauma of replacing a PACS system at the end of its life cycle is reduced, as an example. This also complements the structured data archiving solutions that are emerging and I think are really being driven by merger integration. We've just, at Cadence, we're an Epic shop, and we've just sunset the legacy McKesson EMR and maintain access to that via an archival solution. Clinical integration, we talked a little bit about that previously: better outcomes, better experience, easier referrals, increased patient confidence when their image is really there when they show up for the appointment. It's like, wow, you must really be connected with my doc because you do have my information. And then certainly the lower costs, and that's becoming a bigger deal with the value-based care and the ACOs and the PHOs. So transitioning from strategy, great thoughts, to the rubber meeting the road in operations, these are some of the components of our enterprise information management roadmap. So business strategies driven by the merger integration, clinical integration, and the value-based care. The technology drivers, I talked about the application portfolio and rationalizing that, and then the concept of deconstructed PACS. I think it's important that you consider getting started and, in the notion of a roadmap, things that happen now, next, and later. One of the first things, is, understand where you are with the integrated EMR platform. Image exchange is another good place to start because it delivers its value just by the ability to import images from other places. And then the things that take a longer lead time that are worth starting soon have to do with the MPI cleanup across the various systems contributing, and then starting to fill the pool of the vendor-neutral archive. The next slide talks about high-impact capabilities, and we all are struggling to do more with less and make the best use of our available investment dollars and the available cycles of our smartest people. So this is an interpretation of the 80-20 rule. High-impact capabilities generally add value to a business as the maturity of that capability increases. It's not a new concept, kind of came out of Carnegie Mellon with capability maturity models, for those who are interested in learning more about that. These are some of what I think are it's a representative list of high-impact capabilities of a health system. I didn't want to take a lot of time with the orange and blue boxes on the right, but the notion there as representative is that not everything is equally important. There are, 10, in my opinion, 8 to 10 things that really make a difference across the enterprise performance. Some of them have to do with revenue generation, the others have to do with expense management, but it's the pursuit of those things that's important in your strategy development. So things like value-based care, supporting inbound referrals for your service lines. Those are high-impact capabilities of the business because it instills confidence, provides patient safety and transitions of care, kind of a newly important capability of our extended health systems. Clinical decision support, being able to look at old images, and then research and education. Business capabilities like this, the high-impact capabilities, are enabled by things like strategy, people, process, and yes, of course, technology, but technology alone won't do it. When we think about some of the future state technology enablers for some of these high-impact capabilities, they include these things. Diagnostic image capture, the advances in that front, it's incredibly exciting, what might be in the next 10 years compared to what we have now. You can bet that, storage is going to closely be correlated to the precision of those instruments. So bandwidth and storage, which is, kind of the buzzword of the decade now is, the cloud configurations. And whether it's your cloud or someone else's cloud, we're really talking about, secure, flexible, affordable access to images from a variety of sources. I think image exchange is important as an enabler of, as a subcomponent of HIE. Talked a lot about vendor-neutral archive already and deconstructed PACS. The universal viewer as a concept enables you to help streamline the workflow in the radiology workshop and get away from the swivel chair workflow to something that's a little more streamlined, especially when you're thinking about images captured across diverse PACS platforms at points across your health system. The EMR implications for DI and image distribution, and it's certainly driven at least minimally by meaningful use. We'll talk a little bit about that, but it's really raised the bar in terms of what our clinicians and patients, as they look at things like patient portals, are there. So technology is just one category of those enablers. So you ought to be thinking about, how many high-impact capabilities within your enterprise would light up with a mature enterprise image management enabler. If you could wave a wand today and have that, think about what it could do for your business partners. So the next slide really is kind of a working paper from some of the reading and research that I did for this topic. So really not original work, except I'm a framework guy. So if you look at the first column of these are characteristics of different evolution of PACS. So the locus of control, the customer focus, reimbursement model at the time, things that disrupted it, and then the clinical focus. So you think about version 1.0 of PACS, characterized by the transition from film to digital, and what did that do to some of the big film sales companies that dominated healthcare? The locus of control was primarily radiology-centered. The physician would drop in and converse with the radiologist, perhaps look at the same image at the same time. The customer focus then was that referring doctor, and PACS was a differentiator. Organizations kind of raced, it was an arms race to make sure you had PACS capability so that you could service the doctors. Reimbursement model evolved to be, fee for service. The big disruption was film to digital, and the clinical focus was really on the radiologist. Moving to 2.0, then the focus became more on the workflow, throughput, and efficiency of radiologists. So the heyday of the concession stand, making a lot of money on more procedures, and the locus of control then shifted to things like web-based thin clients integrated with EMRs. So with the clinical focus on other ologists, so in addition to the customer focus of version 1.0, we add the integrated delivery networks, and PACS was really now not as much a differentiator, but the ability to distribute images became the disruptive force. In 3.0, and that's pretty much where we are now, where we're trying to enhance the value proposition of our offerings to our customers, including the quality, safety, and efficiency. The locus of control is much more federated across, in fact, even organizational boundaries of both owned and affiliated. But add the customer focus to include payers and the government, who kind of have have a horse in the race. And reimbursement model is clearly changing to be a blend of fee-for-service with fee-for-value. The disruption is around the deconstruction, and the clinical focus continues with the referring physicians and the patients. So if you think about image management now, next, and later, things you can anticipate on the road ahead, it's a market where there's a lot of incentives for better, faster, if not cheaper equipment. The value prop is on effectiveness and perhaps length of stay and patient outcomes, but these new machines aren't usually cheaper than the ones they replaced. Power to the people with your own devices and pictures and personal phones and videos is a factor that I know that we're wrestling with, and how to manage that. Migrating images, the pace at which you need to do that is important to consider, and the reason why you should start early with not just the image transfer, but the master patient index cleanup that's required to do that, to keep it all straight. We talked about consolidation already, both on the provider side and as well as the vendors, storage, and then the image sharing. There's issues regarding the chain of trust and bandwidth, and we'll talk about stakeholders in your organization you should involve with some of those things. But I think the important thing is you can't wait for too long to get started, because the lead times are significant on some of these. So I'm personally new to the role of the CIO, as I described earlier in my introduction, but so here's what we're focused on in terms of where I'm trying to contribute. First of all, in understanding and anticipating the strategic direction of the enterprise. So what we try to do at Cadence is understand the business and where it's going, and try to bring insight to the business from what we learn from other organizations, and insight that we deduce from thinking about current process in new ways. I've helped facilitate the development of a image management roadmap. It's a 3-year planning horizon, involved stakeholders to help ensure buy-in, and it offers you a framework then for multi-year capital investments. It's very important, I think, to maintain an enterprise view versus silos. I talked about bringing insight, especially to service line development. In our health system, it's really our strategic service lines where the innovation occurs, and that's where it's been really the tip of the spear of our strategic growth agenda has been through our service line. So helping to enable those advanced, complex services to be delivered with things like imaging is important. Keeping up with the technology advances and always considering the opportunities for platform consolidation, especially in this era of mergers and integrations, where suddenly you've got multiple households full of furniture in your living room, and how many sofas do you really need? So the starter list, and I wouldn't say this is exhaustive of some of the key stakeholders that you're going to want to engage. The Chief Medical Information Officer, and Tom Moran's our CMIO, and he's an amazing partner. Really helps in the area of solution architecting with how this all fits in a solution for patient care delivery in the EMR. Physician champions, what do they really need? With your diagnostic imaging folks, what's in the pipeline for new gizmos? You'd like to know that stuff before it shows up in somebody's office as a server that needs to be installed. We've had that happen. I've talked about the innovation that happens at our service line area. New at Cadence in the last year has been the growing up, the maturation of our ACO, and so we're in the early stages of some of those value-based contracts, and they'll have a a stake in the game as well. And privacy and legal. There's a lot of things there related to sharing of data as well as how long you need to keep things. So they're critical stakeholders. So we're all juggling priorities. I know in our case, insatiable demand with finite supply. So, where is IM on your list is the question. It's very easy for it to get lost in the shuffle. Clearly important, not always urgent. This is probably not something that end user is going to come pound your desk to demand. It's something that you're going to have to anticipate and build a business case for based on your insight to where the business is going. I want to underscore the advantage of the multi-year investment horizon and the lead times, and some of the triggers that may pique your interest in this would be the need to upgrade or replace a PACS system, merging with another organization, perhaps a major upgrade or implementing an EMR, or service line growth and trying to do a better job at managing referrals within your health system. A couple more slides here. So some of us work hard for the money regarding meaningful use, but it's also good. It's also good practice. Stage 2 final rule, that the results have to be accessible through a certified EHR, because it allows providers ease of access when they're doing a patient encounter, and it also avoids repeat tests. So you see all three legs of the triple aim stool there: outcomes, experience, and lower cost potentially. So in conclusion, some of the things I would suggest as you think about image management, put the patient in the middle, not the ologist. Think of a beloved elderly relative and put the patient in the middle. Consider the 3-year roadmap. I think that's a good use of some consulting dollars, especially regarding subject matter expertise if you don't have it in your shop. Understand and embrace the concept of deconstructed PACS. I'm a big believer of staying close to the innovation that's happening in the service lines. And look at your EMR as the shared documentation tool. We're actually trying to push the PACS to the workbench and get the documentation in the EMR. Consider going RSNA with one of your DI colleagues, and avoid underestimating the time and cost, and don't put too much weight on a single vendor platform. So with that, I'll conclude my comments. Anthony?
All right. Very good, Dan. Thank you so much for that presentation. Now we are going to hear from Troy Oliphant. Let me just get your slide forwarded there. And Troy is Global Healthcare Solutions Manager with Perceptive Software, our sponsor today. Troy, thanks for joining us. Thanks for sponsoring.
All right. Thank you, Anthony. Dan, that was really a very interesting discussion. I'm looking forward to the Q&A. And to that end, I will be brief so we can get to the discussion. So a little overview about Perceptive Software. We're a medical content management company. We're eliminating data silos and delivering complete patient information within the EMR, a single platform to capture, access, manage, and share all content from medical images to documents. Solutions include vendor-neutral archive, enterprise content management, and enterprise image connectivity. As you can see, we're a truly global company with over 3,000 customers and in use in over 30 countries. To go with what Dan was saying earlier, there's just an explosion in data. It is no longer just medical images, not just the multi-slice CT and PET CTs that are putting out thousands of images, but now it's also wound care and PDFs and TIFFs and JPEGs. And it is, we routinely here at Perceptive are now transferring petabytes of data per facility. And the days of, well, to go back on what Dan said earlier as well, the days of the radiologist being the lone consumer are gone. Now it's a matter of going across all of those silos and making an imaging backbone that is not just DICOM or radiology specific. This is the deconstruction of PACS, and to some degree, the rebuilding of an imaging workflow that is no longer just about PACS or just about a single department. It's now about bringing all of the different image types into a single archive and having access across the entire enterprise with any device. As you can see, with Perceptive software, what we're really striving for is medical content management, not just clinical content, but all content. It's a combination of the vendor-neutral archive and the electronic content management system. So it's all content from clinical workflows and the back office software. And then we run a wide range of clients, from the smaller imaging centers up to large IHEs, and even over to, as an ex-military person, something I'm proud of, to the U.S. military. And with that, Anthony, I will give it back to you.
Oh, very good, Troy. Well, thank you. And again, thanks to Perceptive for sponsoring today. Now we have time for a Q&A. So as I mentioned, go ahead, type your questions in the Q&A box, leave the default set to all panelists, and we will take a look at those. Dan, let's talk a little bit about change management as it relates to the imaging space. You mentioned key partners such as the CMIO, but as with any technology change, you want to make sure that the folks that are going to be using the technologies are involved in decision making. Some of this stuff is sort of underneath the covers and they may never know it, but how much of this does bubble up, and how much do you want to have the folks on the ground involved in, to some degree, in making the decisions that they're going to have to live with?
Thanks, Anthony. Yeah, so the change management, if it wasn't for the people, this technology business would just be so much easier. But, so organization change management is really the enzyme of a lot of our more complicated solutions. So we approach that in a number of ways so when you extend the planning horizon with a 3-year roadmap, you have time to get folks on board, and there's an opportunity to build some trust that they're not getting what they think they want today because they can see it's coming next year or the year after. So that's certainly a part of it. And I think it's starting with the business. So it's not just the technology, but what is it that we're trying to do? And so, we're in the process of bringing on board a large orthopedic practice that previously had their own PACS system, and orthopedists doing pretty careful read of the X-rays. And so as we bring them into the health system technology platform, we are working through with them on that whole workflow in advance of cobbling together the technology, and that has to do with business and contractual relationships with what radiology groups doing what reads for what part of the business, and so there's a lot of complexity to it. So that's any of those things can hang you up on the path to a solution. And I think I'm not a change management expert. I'm fortunate to have some of that capability within my IT organization, and it's about understanding what the stakeholder, what it means to the stakeholder, communicating the positives, things, what's going to change, what's not going to change, why is it changing, when is it changing, frequently, and just helping them get on board. Some of the discussions are harder than others, but if we go back to putting the patient in the middle and having a consistent workflow for the health system, we're prevailing more often than not.
Great. You mentioned the multi-year horizon as a benefit in implementation. Did you also mean to suggest that from a budgeting point of view and absorbing this in a financial sense, it makes it more palatable?
Yeah, I think that most of the CIOs on the phone would appreciate the annual wrangling over capital dollars. And, these solutions aren't cheap in terms of capital or operating costs. So to the extent you can spread it over multiple years, you're better off than if you suddenly have an organizational imperative to wave a wand and deliver this. You're going to pay a lot in 1 year just to establish the platform, and you can pay to accelerate the migration of images. But if you have a little more time, you can do it yourself, so to speak, with the tools that come with some of the products out there. It definitely is an advantage. Kind of like with ICD-10, if you waited till the last minute, you got hammered with a lot of stuff. Whereas if you spread it over multiple years, it was more palatable.
Right. And regarding meaningful use, you mentioned that what they have in there does cover the triple aim. So it sounds like you were supportive of what's in there. And is that the case? And what do you think about going forward, what they might start to require, and how you kind of skate to the puck and envision what the government, knowing some of the other trends that are taking place, lower cost and reduced duplicative testing, where do you see this all going as far as what the government might require under Stage 3 or some other programs?
Yeah. So I think that the Meaningful Use program has been effective for kind of getting everybody into the pool, so to speak. And certainly we pursue, positive results in terms of our participation in that program, and wouldn't want to leave those funds on the table. But that is not our primary driver. We're not doing it just for meaningful use. We're doing it for, meaningful care delivery. And so, we'll be mindful. We've got a small group within the health system that's focused on MU and programmatically making sure that we're delivering on the metrics. But that's not a big driver in our strategy.
You mentioned, or you show on one of your slides, you mentioned being a framework-oriented guy. Can you talk about how others may, if that's a way other CIOs might categorize and manipulate information in order to come out with some good strategies and decisions? Just tell us more about what that means and how you take information and what it means to be a framework person and how that helps you be successful.
Well, I think this is, I describe myself as the recovering consultant, and so, I draw pictures a lot, and I guess it's context. It's also a good basis to facilitate collaboration. So I start drawing a picture with 2 or 3 people in my office, and all of us are always smarter than any of us. So I think the frameworks help you to communicate what you're thinking and help others contribute to the solution that you're thinking about, either pointing out things you missed or emphasizing something that's of high value. So there's some of these things I've had my black bag for more than 20 years. They still work. But
it's like the screwdriver and the wrench, right? They never go out of style.
Right.
Very good. Imaging would you say imaging is an area where the CIO often has to manage multiple vendors, for example, an imaging vendor and an EMR vendor, or is that something where those two are handled in-house and those two don't need to interact, so you don't need to be a third party bringing 2 vendors together and getting them to collaborate?
Yeah, our approach with those vendors is, there haven't been many times in my tenure now, just over a couple of years, where I've had to have both vendors at the table. I think we work well independently, with kind of my team being the pivot. Epic's our enterprise EMR, And, we've got, even on just our side of the merger with Northwestern, we've got 3 different PACS systems. And so it's more, it has not been an issue of trying to have to pull vendors together. I mean, that's the dream, right? That more of these things are plug and play, but I think it's going to be a ways off.
Just as a final question, any more around ROI and having successful conversations with the CFO when the CIO has something like this in their sights and there's some dollars that need to be allocated? What's your best talking points with the CFO to try and get those, the CFO and the CEO and the board to get those dollars approved?
Mm-hmm. Yeah, good question. And, I think the roadmap helps with that. I think the drivers, at a minimum, include the portfolio rationalization. So at some point you'll be able to, move to a common. The alternative is to move to like one PAC system, but that's also expensive and includes a lot of the same image migration things. So, and I think if you parcel it out, you can have a program and have a little bit of capital every year. So I think in terms of the ROI, anything over $1 million has to get vetted with the board, and this certainly was in that category. And it was our IT strategies are on 3 pillars. One was establishing a solid enterprise platform, and this is part of that, but also preparing for merger integration, so that as we would acquire other organizations, that we're able to assimilate and get a single repository for some of the images. And then the third pillar is the clinical integration. So enterprise platforms, merger integration, and clinical integration. And it was around that we got the support that we've had so far.
Very good. Well, I want to thank you so much, Dan, for giving us that great presentation and the Q&A. I want to thank our sponsor, represented by Troy Oliphant and Perceptive Software, for sponsoring. As I mentioned, you'll receive an email when our archive recording is ready, usually within 2 business days, and a separate registration is required. If you've asked us to communicate your attendance to Chime, we'll do that so you get your CHCIO credits. If not, don't forget to claim them yourself. Excuse me. Attending each webinar of ours gets you 1 CEU. Questions, comments, please contact me and go to our site to view our upcoming schedule and last 12 months of archived events. So with that, I want to thank everyone again for joining us, and have a wonderful day. Thank you.